What's up everyone? Welcome back to my channel. So actually this video will not only be posted on my channel but also to our colleges or our sections YouTube channel which I will put the link down below. So for today, I know you are used to my nonsense content, though I don't have many views. Yeah, I know people really don't like watching my channel because of the nonsense content, but today I'll try to have some sense in my content. So today with my final brain cell.
It's the final brain cell.
I will try to give my best to discuss to you what is hyperproliferative anemia and so as to other anemias under it like iron deficiency anemia and anemias in renal disease. So shall we start?
Aye, aye, Captain!
Okay, let's go! By definition, hyperproliferative anemia is a production of an adequate number of erythrocytes or red blood cells to maintain homeostasis. The hallmark is low reticulocyte count, or reticulocytes are simply, let's call it as baby RBCs or young red blood cells, which may be this may be due to bone marrow failure, bone marrow replacement, inflammation, or nutritional deficiencies. We have learned about what is hyperproliferative anemia. We have already defined it. So let's define also what is iron deficiency anemia. So iron deficiency anemia is a type of anemia that occurs when there is an inadequate intake of dietary iron that will be utilized for hemoglobin synthesis. However, even if your body has adequate iron stored, iron deficiency can still occur if the iron supply in the bone marrow is not enough. This type is referred to as functional iron deficiency. Very functional iron deficiency. Okay, so iron deficiency anemia is the most common type of anemia worldwide. In developing countries, it is due to lack of nutritional intake, as well, and also in the developed countries, it is caused by acute blood loss due to GI bleeding or peptic ulcer disease. Okay, I almost said peptic. IDA is the most common cause of nutritional deficiency worldwide. So IDA, let's use it here in the video that IDA is iron deficiency anemia. We'll use that short term because it's very saliva spending saliva spending, my god. So it's okay, let me use right terms, okay? So iron deficiency anemia is a very saliva spending and sometimes it becomes a tongue twister to me. So
Oh, Dexter. Oh, say it again, Dexter.
anyway, let's go. So before we go further, let's take a quick review of our anatomy and physiology first. I know it's already in the link part, but why not? For the review, if you take a look inside a single RBC, it contains millions of hemoglobin proteins. So this RBC right here contains millions of hemoglobin proteins inside it. And then these hemoglobin proteins binds to the oxygen, which means RBCs becomes an oxygen transporter that could deliver oxygen throughout the body. And I believe we all know that. So if we try to look deeper to the hemoglobin molecules as percentage shown here in the side, they are made of 4 heme molecules. In the center of each heme, this one here is just a single heme, so you can find an iron molecule in the center. This iron binds to the oxygen molecule. Therefore, each hemoglobin can bind up to 4 oxygen. Additionally, iron is an important part of certain proteins like myoglobin, which delivers and stores oxygen in muscles, and also cytochrome oxidase that aids in production of adenosine triphosphate or ATP. So normally, in a daily basis, we lose up to 1 milligram of iron. So it may be through sweat or cell shedding, but cell shedding, cell shedding, CELL shedding, yes, that's it. Okay, but however, there is nothing to worry about this since we take about 10 to 20 milligrams of iron every day, and with this 10 to 20 milligrams of iron, you absorb 10% of it, which equates to 1 to 2 milligrams, so it's just balances out. So balance out on that. There are 2 types of iron: heme iron and non-heme iron. For the heme iron, it binds to the hemoglobin and myoglobin. The sources for these are mostly found in meat, like pork, beef, and such. So, and then iron in this type is in ferrous or Fe2 phosphate. Earlier, the other type is the non-heme iron, which is in ferric or Fe3 phosphate. The sources for these are the plant-based, like spinach or green leafy vegetables and beans and such. Yes. How does heme iron and non-heme iron is processed in the body? So, the heme iron breaks down in a duodenal cell and then ferrous is released. Whereas in the non-heme iron, it needs to be reduced first. The hydrochloric acid from the stomach activates the ferroreductase in the duodenal cell, which converts non-heme iron to ferrous, and then the ferrous will combine with the ferritin, and where it will be stored temporarily. So, if the body needs ferrous or Fe2+, they are then released, and then so shunt released, and then there are times that the excess ferrous will be converted again by an enzyme called prognosis to ferric acid. So the excess Fe2+ will be converted again to Fe3+ by prognosis. So the converted again Fe3+ will then bind to iron transporters called transferrin. The ferric will be delivered to the target tissues and will be stored there where there are more ferritin and will be converted back to ferrous when needed. Now let's jump to what causes iron deficiency anemia. So we have 4 main causes of IDA. The first is the decreased intake. Decreased intake. Yeah, decreased intake. This is common worldwide since meat supply, which is the number one source of heme iron, cannot meet the demand. So you don't need to be confused with this when you say meat supply cannot meet the meat demand, because let's have it this way: it's MEAT supply cannot MEAT the MEAT demand. So it's MEAT and MEAT. I think I'm the only one who's confused and finds it funny. So if you don't want to laugh, it's okay. Yeah. So moving on. The infants or babies can take less of iron because breast milk contains only small amount of iron. The American Academy of Pediatrics advises that babies need to have supplemental iron of 1 milliliters per body kilogram, and it should start on baby's 4th month. Also, vegetarians or vegans are also at risk because, as what we have mentioned earlier, plant-based source has non-heme iron that is in the form of Fe3+, which is harder to absorb because it will take time. Yeah. So anyway, we have the second cause. We have the decrease in absorption. Probably the decreased absorption is probably because of the decreased stomach acid after a gastrectomy. So when you undergo gastrectomy, a part of your stomach is removed. So the HCl or the stomach acid production will be reduced, and synthesis or the conversion or the absorption of Fe2+ will not take place that much. And yeah. So, or it could be caused by inflammatory bowel disease or celiac disease that causes inflammation and destroys the duodenal cells. Yes. So, for the third, we have the increase in demand. The increase in demand is common with children and adolescents since they are undergoing rapid growth and their blood volume is continually increasing and their body requires more hemoglobin due to this. Also, it occurs with women in having pregnancy or pregnant women since there is an increase in iron requirement due to fetal development. Last but not the least, we have the increased loss. This is common in persons with chronic slow bleeding, like women who has frequent or heavy menstruation, or those who experience bleeding because of gastric ulcer. So, ladies, be careful. Make sure to take your iron supplements if it's recommended by the doctor. Increased blood loss is also noted on elderly males with colon cancer because IDA is colon cancer's first symptom. Yes. And then also Helicobacter pylori also cause increase in loss of iron because it causes gastric ulcers and GI bleedings. GI bleeding. What's bleedings? Okay. Sige, continue. The Helicobacter pylori also sucks dietary iron for itself, which prevents iron from reaching the duodenum. Say it again. Duodenum. Basta mo na. D-U-O-D-E-N-U-M. Duodenum. Yes. So in the developing countries, hookworms may also increase in blood loss. Why? Because they lodge in intestines and sucks out blood. So you have to be careful with these hookworms and Helicobacter pylori. You should be careful from and avoid from acquiring them. You should always clean your food. Wash your food, cook it very well, and always take care of yourself, people. Since we already have tackled we already had a review and then had the causes for IDA, now let's have the pathophysiology of IDA. What's the process the body undergoes during or when we have IDA? So, with the causes mentioned, they result in lack of iron in the body, especially in the bone marrow, where the biggest reserve of iron in the body is found. Because we all know that bone marrow is where the RBCs are produced. So yes. Since there's a lack of iron, there is a great chance that the iron will be utilized to synthesize heme is not enough, which means hemoglobin will also not be enough. And I think that's a very understandable part. So if there is insufficiency in hemoglobin, the synthesis of RBC in bone marrow will also decrease, thus resulting to anemia. So that's it. Yeah. So in a laboratory result, a person with anemia will show the following. Hemoglobin. For the hemoglobin, women will have less than 12 gram per deciliters, and for male, they will appear to have less than 13 grams deciliters of hemoglobin. However, symptoms usually starts manifest at 7 to 9 grams per deciliter. Now we have the signs and symptoms of IDA. Aside from the one I mentioned earlier, like the laboratory results like the hemoglobin and hematocrit level, we also have different signs and symptoms of IDA or iron deficiency anemia. First, we have here the PICA. No, PICA. No, not necessarily. PICA. That's PICA. The lack of iron in the body affects the CNS, or the central nervous system, via complicated mechanism, which results to iron-seeking behaviors like PICA. PICA is the having of cravings to eat non-nutritive substances like dirt and ice chips. We also have the decrease in ferritin levels. So as you remember, ferritin levels, or ferritin, stores the ferrous or the ferric or the iron in the body. So the lack of iron in the body means lesser iron binds to the apoferritin that is stored as ferritin. Therefore, ferritin levels will be less than 12 nanograms per milliliters. This also means that the ferrous won't be stored properly. So if there's lack in ferritin, ferrous will not be stored. Okay. Next, we have here the high TIBC. TIBC means total iron binding capacity of transferrin. So it was mentioned earlier, transferrin are ferrous transporters. Yes. Okay, lack of iron will also increase the levels of iron scavenging proteins that are ready to get every iron that they find, thus causing high TIBC. We also have the low mean corpuscular volume. RBCs will contain lesser hemoglobin and result to RBC having decreased cytoplasmic volumes, and their cytoplasms appears to be pale. So in the CBC, it will appear that the MCV value is less than 80 femtoliters. Also, we have the pallor or appearance of being pale in the conjunctiva, lips, nails, and palms. This sufficiency in hemoglobin causes decrease in RBC, which makes the blood less red, thus causing pallor. We also have cholelonychia, which occurs in 5.4% of patients with IDA. It is thought to occur due to the upward deformation of lateral and distal portions of pliable iron-deficient nail plates under mechanical pressure. So, for those of you who don't know, cholelonychia is this. So, it appears to be the flattening of our nails. And also, we also have angular stomatitis, which is the mechanism is unknown. So now we are going to discuss about the medical management for IDA. So IDA can be treated with iron supplements taken by mouth or oral iron supplements, like those available in the groceries or in the pharmacy. You can just buy ferrous sulfate and like that. Also, it will help. Also, eating foods high in iron and foods that will help in the iron absorption of the body is also advised for you. So what are these foods that help in the body's absorption of iron? We have foods that contains vitamin C, like the oranges. Iron can also be given through intravenous or IV infusion if the iron supplement or the oral iron supplements is not enough to replenish the lost iron in the body. And also the transfusion of red blood cells is sometimes advised if it's severe. Yeah. Anemia can be corrected within few months with proper diet and medication. However, patient has to continue taking iron for 6 to 12 months to completely replenish the iron in the body. Moving on, for the prognosis of IDA, the short-term prognosis for most patients is excellent because you can really recover from IDA. However, if the underlying cause is not corrected, if your IDA is caused by something, the prognosis is poor. Chronic iron deficiency can lead to death from an underlying lung or heart disorder. So if you're experiencing signs and symptoms of IDA, it's better that you consult a physician so that you will know what to do and what medications you will take. Okay? So now we are going to discuss the anemias in renal disease. Anemia is a characteristic of moderate to advanced CKD. The moderate to the advanced CKD is because CKD has stages, and then anemia starts to manifest or develop in stage 3. So the anemia of CKD is normochromic to normocytic with an HCT or hematocrit level of 20-30%. However, if the patient has polycystic kidney disease, he or she might have 35 to 40% hematocrit level. What are the causes of anemia in CKD or chronic kidney disease? The causes are relative erythropoietin deficiency, bleeding problem, chronic inflammation, folate or B12 deficiency, hemoglobinopathies, and immunosuppressive drugs. Those are the causes for anemias in renal disease. Now we are going to discuss the pathophysiology of anemia in CKD or in renal disease. So, iron and EPO or erythropoietin are crucial for red blood cell production in the bone marrow. Iron availability is controlled by the liver hormone called hepcidin, which regulates the dietary, iron absorption, and macrophage iron recycling from senescent red blood cells. There are several feedback loops that control hepcidin levels, including iron and EPO. In CKD patients, hepcidin levels have been found to be highly elevated, presumably due to reduced renal clearance and induction by inflammation, leading to iron-restricted erythropoiesis. So CKD also inhibits EPO production by the kidney. So there will be reduced EPO production of the kidney, and may also lead to circulating uremic-induced inhibitors of erythropoiesis, which shortens the red blood cell lifespan and increase blood loss. Thus, these factors lead to anemia in renal disease. Now we are going to talk about the signs of symptoms. Actually, the signs of symptoms are more or less the same with IDA. We have the fatigue, tiredness, shortness of breath, unusual pale skin or pallor, weakness, body aches, chest pain, dizziness, fainting, fast or irregular heartbeat, headaches, heart problems, and trouble concentrating. So for the medical management of the anemias in renal disease or anemias in CKD, we have here the recombinant human ESE or erythropoietic stimulating agents. So what is ESA or erythropoietic stimulating agents? ESA is a synthetic version of erythropoietin or EPO, and it is given to those who lack or have decreased or who have decreased in EPO. And then there are even issues or articles that are written that some athletes abuse ESA because they want to increase their blood volume to increase oxygen capability or capacity to be able to perform more. Also, another medical management is B12 and folate administration, since it is the cause of deficiency, so we should cover up for the deficiency. Also, dialysis is another medical management, and though it is applicable to IDA, but however in the anemia or anemia in CKD, blood transfusion is not much considered anymore because of the presence of recombinant human ESA. There are also factors that are considered before doing blood transfusion with patients having CKD. First, there could be iron overload. Next, there is possibility of infection. And then last but not the least, there is allo antibodies, where in case the patient had undergone renal transplant, these allo antibodies might attack the donor's kidney, thus causing problem with the transplant. Surgical management is the renal transplant. Anemia in CKD, since we all know, I've already have discussed or talked about anemia in CKD starts in stage 3, or when the kidneys GFR or glomerular filtration rate, again, let's say it again, glomerular filtration rate or GFR is at 30 to 44 milliliters per minute per 1.3 meters squared. So at this rate, treating the underlying cause can also treat the anemia. For the prognosis of people who have anemia in their CKD.
Oh, say it again, Dexter.
CKD, ay! CKD. People with CKD, severe anemia, can increase the chance of developing heart problems because the heart is getting less oxygen than normal and it's working harder to pump enough red blood cells to organs and tissues. People with CKD and anemia may also be at an increased risk for complications due to strokes linked. So, therefore, the prognosis for people with anemia in CKD is it doesn't have a nice prognosis. However, you cannot really prevent having anemia in CKD, but you can control your CKD not to reach or not to develop to stage 3, because that's where it starts, the anemia starts. Yes. So, for the diagnostic and laboratory procedure of IDA and anemia in CKD, bone marrow aspiration and biopsy is the definitive method of establishing the diagnosis of iron deficiency anemia. Yes, it is. So, a bone marrow biopsy is usually done if your healthcare provider thinks that you have a problem in making blood cells. Aside from the bone marrow aspiration and biopsy, the definitive one. However, we can also have the less painful, yes, the complete blood count, or what we know as CBC. So CBC is the blood test used to evaluate your overall health and detect a wide range of disorders, including anemia, infection, and leukemia. So a complete blood count test measures several components and features of your blood, including RBC, which carries oxygen. It also checks the hemoglobin level, hematocrit percentage, and MCV levels. So during a CBC or during the CBC procedure, yes, a lab technician or the med tech will draw blood from your vein, and typically from the inside of your elbow or from the back of your hand. Inside of your elbow, here, this part, or the back of your hand. And the test will only take a few minutes. Yes. But usually, I haven't experienced yet undergoing CBC that my blood samples was from here. It's always here. So other laboratory and diagnostic procedures are hemoglobin electrophoresis. Okay, I'm having difficulty in pronouncing this one. Okay, let's try it again. Hemoglobin electrophoresis. Okay, hemoglobin electrophoresis. Okay. This test looks at the different types of hemoglobin in your blood, and it can help you diagnose which type of anemia you have. Also, we have another kind of test, the reticulocyte count, or the counting of baby RBCs. Yeah, I call it baby RBCs because it's easier to remember that if you talk to persons who are not in medical field. So reticulocyte simply means baby RBCs. So reticulocyte count, this test measures the number of young red blood cells in your blood. The test shows whether your bone marrow is making red blood cells at the correct rate. So if there's an abnormality, maybe it means that you have anemia or other diseases that may be related to it. Okay, so now we also have tests for the level of iron in your blood and body. This test includes serum iron and serum creatine tests. We also have the transferrin level and the total iron binding capacity test. Also measures iron levels. We are going to discuss about the nursing diagnosis and intervention. So why am I discussing nursing diagnosis and intervention? Simply because I am a nursing student and this is part of our med-surg requirement, medical surgical course requirement. Yes. First, nursing diagnosis is the fatigue related to decreased hemoglobin and diminished oxygen carrying capacity of the blood, as evidenced by increased rest requirements and reports of fatigue and lack of energy. So, what should be our nursing interventions here? First, we have to assist the client or caregivers in developing a schedule for their activities of daily living and also their scheduled rest. Next, we also have to stress the importance of frequent rest periods because they need that. And then we also have to monitor the hemoglobin, hematocrit, RBC count, and reticulocyte counts of the patient, especially if they are admitted in hospital, so we can see their development. And then also we also have to educate our patients with energy conservation techniques. Encourage patients to continue iron therapy for a total therapy time of 6 months to a year, or as mentioned earlier, yes, I've mentioned it already earlier, 6 months to 12 months. Even if the fatigue is no longer present, because it will take that much time to replenish the iron. Even though you are not tired anymore, but your iron is still not sufficient, you might, if you stop taking your supplements, it might just come back and you just go back to square one. So inulit one girl. For the next nursing diagnosis and prevention, we have the deficient knowledge related to the complexity of treatment, lack of resources, or unfamiliarity with the disease condition, as evidenced by questioning members of the healthcare team. For the nursing intervention, because I'm talking so much here and then my video is taking so long. Yes. So we have first, since it is deficient in knowledge, explain the importance of diagnostic procedures such as CBC, bone marrow aspiration, and a possible referral to a hematologist or expert in blood. And then also experience the importance of iron replacement and supplementation in the body. And then educate the client and the family regarding foods rich in iron. Continuation, the risk for infection related to bone marrow malfunction. So you should assess for local or systemic signs of infections such as fever, chills, swelling, pain, and body malaise. You should also monitor the white blood cells or leukocyte counts in the body and anticipate the need for antibiotic, antiviral, or antifungal therapy. I think it depends on what caused the infection. Next, you should instruct the client to avoid contact with people with existing infections. And then stress the importance of daily hygiene, mouth care, and perineal care to avoid infections. So cleanliness is still the best. And amidst this COVID pandemic, I encourage you to wash hands every day for 20 seconds every after 30 minutes and use alcohol or hand sanitizer. Bring those whenever you're going out, and don't just easily touch metal surfaces, plastic surfaces if you don't know to even touch that or whatever in there. If possible, you should wear gloves like that, wear your mask, your face shield, practice social distancing, and if you have nothing to do outside, please just stay at home. So for the next nursing diagnosis, you have risk for bleeding related to bone marrow malfunction again. So in this, the intervention for this is instruct the client in dietary modifications to reduce constipation. Eating a high diet fiber and drinking a lot of fluids to avoid constipation, or using a stool softener and other laxatives as prescribed if having difficulty in passing stool. Next, instruct the client about bleeding precautions. Instruct the client to use an electric shaver, not razor, when shaving, and then use a soft toothbrush when brushing. Yes. And instead of using for women who have menstruation, instead of using pads, using tampons, use pads. And to avoid rectal procedures such as suppositories, Anemias, and rectal temperature readings. Avoid those if you have anemia. Aside from the avoidance of rectal procedure, you should also use water-based lubricant during sexual intercourse to reduce the friction, because friction causes bleeding. Use water-based lubricant, not oil-based, because it irritates the skin. Use water-based. Remember that people, community, who are sexually active, it's a reminder for you. You might have anemia, and you have to use KY jelly. This is a reminder from me. So another is anticipate the need for platelet transfusion once the platelet count drops to a very low value. Platelet replacement may be required to reduce the risk of bleeding. Pre-medication with antihistamine and antipyretics to reduce transfusion reaction side effects. We also have the last but not the least, the activity intolerance related to imbalance between oxygen supply and demand, as evidenced by generalized weakness. For the nursing interventions, encourage deep breathing exercises or technique and administer oxygen as prescribed by the physician. These methods boost oxygen delivery to the tissues. And then also allow patient to verbalize feelings regarding the limitations. This helps the patients cope. Acknowledgement that living with activity intolerance is both physically and emotionally difficult. So, also, gradually progress patients' activity with the following, like their range of motion, having exercises in bed, gradually increases duration and frequency, then the intensity to sitting and then standing. Also, you can have deep breathing exercise 3 or more times daily. And then also sitting up in a chair 30 minutes 3 times daily. Also, you can also have the patient to walk in the room for 1 to 2 minutes 3 times a day, and then also walking down the hall 20 feet or walking through the house, and then slowly progressing walking outside the house and saving energy for the return trip. Yes. And we also have to allow the patient to have undisturbed rest. Lessening any interruptions allow the patient to rest and benefit from sleep until anemia is resolved. So, also, give blood components, commonly packed RBCs, via intravenous catheter as prescribed, only if prescribed by the physician, and nurse cannot give RBC without any prescription. Okay, this method will increase the number of RBC circulating in the blood, which eventually increase the blood's oxygen carrying capacity. Yes. Okay. Yes. Observe and report for any signs and of confusion, action, confirm type, and cross-matching. These measures lessen the risk of transporting the wrong type of blood to the patient. Yes, should always administer the right type of blood to your patient. Should also tell the patient that symptoms commonly are relief and tolerance or activity agrees to the treatment regimen. Treatment may include the PAC RBC or erythropoietin replacement, or the ESA, or again the ESA, erythropoietic stimulating agents. And also have the iron and other supplements, cobalamin, folate. Cobalamin folate may be given to restore the hemoglobin and depleted iron and other deficiencies if necessary. People with chronic disease, usually older individuals, may not have regulatory dietary intake of these substances, so supplements will boost normal erythropoiesis. And then improvement in dietary intake and strength also may help to reduce symptoms. Last but not least, the implement response to each activity. Close monitoring will serve as a guide for optimal progression of the activity. That's it for today. I hope you learned something about what I have discussed in the video. I hope you already understand what is hypoproliferative anemia, iron deficiency anemia, and anemias in renal disease and how do they work and everything. Thank you so much for watching my video, and I very much appreciate it. Thank you so much. So yeah, I'm used to doing nonsense content, and even this video doesn't appear to be good. I'm trying to do my best here. So thank you so much, everyone, and as a friendly reminder, please always take care of your health. Eat a balanced diet if needs. Eat vegetables, fruits, and like that. So you don't have to experience any of these diseases that we have in our channel. Take care of yourself all the time, because there will always be that someone, or there will always be that group of people who loves you, who cares for you, and thinks that you matter. You have your family, your friends. They may not be able to say it verbally. Sorry. They may not be able to say it verbally, but or show it through their actions, but you should know that in your heart include in them. They care for you, they love you. So that's it for today. And if you have questions, okay, if you have questions or corrections with my presentation, you can always approach me on my socials or my Facebook page, Facebook account. It's Jessica Toong Cortezo. For the Twitter, it's at I'm Jessie C, and for the Instagram, it's Joability 2.0. Thank you so much everyone for watching. I love you all and I care for you, and again, you matter.